Ectopic pregnancy, management and guidelines. Based on NIST guidelines. Dr. Avir 2024-07-0. Introduction to ectopic pregnancy. Definition: a pregnancy that occurs outside the uterine cavity incidence. 1 to 2% of all pregnancies' importance, leading cause of maternal mortality in the first trimester. Pathophysiology. Normal pregnancy. Fertilized egg implants in the uterus, ectopic pregnancy. Implantation outside the uterus, commonly in the fallopian tubes. Risk factors: PID, previous ectopic pregnancy, tubal surgery, IVF, smoking. Clinical presentation. Symptoms: abdominal pain, vaginal bleeding, shoulder tip pain, dizziness signs, tenderness, adnexal mass, cervical motion, tenderness, differential diagnosis, miscarriage, ovarian cyst, appendicit. Diagnosis. Clinical assessment, history and physical examination, transvaginal ultrasound. Gold standard for diagnosis: serum HCG levels, abnormal rise or fall. Other tests: progesterone levels, laparoscopy if diagnosis uncertain. Management overview. Options: conservative, medical, surgical choice depends on hemodynamic stability, size and location of ectopic, HCG levels, patient preference. Conservative management. Conservative management. Indications: suitable for stable patients with declining HCG levels and small, unruptured ectopic pregnancies without fetal heartbeat. Monitoring: serial HCG measurements, repeat ultrasound as needed. Follow-up: close monitoring for signs of rupture, patient education on symptoms of rupture. Expected outcomes: resolution of ectopic pregnancy without intervention in select cases. Risks: potential for tubal rupture and need for emergency intervention. Medical management. Methotrexate treatment. Mechanism: folate antagonist that inhibits DNA synthesis. Dosage: single dose regimen, 50 milligrams per square meter intramuscularly on day 1. Multi-dose regimen, 1 milligram per kilogram intramuscularly on days 1, 3, 5, and 7, alternated with folinic acid, 0.1 milligrams per kilogram on days 2, 4, 6, and 8. Criteria for use: hemodynamically stable, no significant pain or minimal symptoms, unruptured ectopic pregnancy, serum HCG levels less than 5,000 IU/L, ectopic mass less than 3.5 centimeters, no fetal heartbeat on ultrasound. Patient is able and willing to comply with follow-up. No contraindications to methotrexate, e.g., liver disease, breastfeeding, blood disorders. Monitoring: HCG levels. Check on days 4 and 7 after administration, then weekly until levels are undetectable. Side effects: monitor for abdominal pain, nausea, stomatitis, hepatotoxicity. Contraindications: liver disease, breastfeeding, blood disorders, inability to comply with follow-up. Expected outcomes: high success rate in properly selected patients. Risks: failure requiring surgery, methotrexate side effects. Surgical management. Indications: hemodynamic instability, severe pain, rupture, high HCG levels, fetal heartbeat, failed medical/conservative management. Procedures: laparoscopy, Preferred approach for its minimally invasive nature. Laparotomy, for cases where laparoscopy is not feasible. Salpingectomy, removal of the affected tube. Salpingostomy, incision to remove ectopic, preserving the tube. Care. Preoperative, stabilization, preparation for surgery. Postoperative, monitoring for complications such as bleeding and infection. Expected outcomes, immediate resolution of ectopic pregnancy. Risks, surgical complications, impact on future fertility. Conclusion, individualized care, tailored to patients' clinical presentation and preferences. Close monitoring, essential for conservative and medical management. Surgical intervention, required for unstable patients or when other managements fail. Patient education, crucial for recognizing signs of complications and adherence to follow-up.